Okay. Hi, everyone. My name is Gwen Driscoll. I'm the Director of Communications here at the UCLA Center for Health Policy Research. What a great turnout in person. I think we've got quite a few people online, too. It's my pleasure to welcome you to our 2015 Health Policy Seminar Series. And before I start, we have gotten requests here, and I'm sure there are folks online who would like to get a copy of Nadi's PowerPoints. We're trying to save trees here at the center, so we did not print them out. However, if you are here in person and would like a copy emailed to you, please see Hala. She's right outside at the reception table after the presentation. She'll get your email and she can send you the slides. If you are online, you can email me, Gwen Driscoll, and my email is gdriscoll, so that's GDRISCOLL @ucla.edu. And we will get this sent to you. Okay. Before I introduce this month's speaker, I'd like to let everyone know about our next seminar, which will take place on April 16th at the same time, noon to 1. Our guest speakers next month are Dr. Stephen Wallace, the Center's Associate Director, Dr. Michael Rodriguez, Director of the UCLA Blum Center for Poverty and Health in Latin America, and Maria Elena Rodriguez, a graduate student researcher here at the center. All three are co-authors of a soon-to-be-released joint report with the UC Global Health Institute on state health policies that impact, for better or worse, the health and well-being of undocumented immigrants, and it should be quite interesting, so please join us. Again, that's April 16th at noon. All right, and I should have had that up. There's the seminar. Sorry. Again, these will be if you miss a seminar, all is not lost. We record all our seminars and place them on our website in our newsroom under Center Videos approximately 1 week after the live event. So you can always check back and see a seminar if you miss it. But of course, if you attend in person, you get to meet the authors and ask questions directly. You can find out all about past and upcoming seminars on our website or by subscribing to our monthly e-newsletter, Health Policy News, with a subscribership of more than 13,000 people. It's the hot e-newsletter to sign up for, so please do. On a final note, this study was funded by the California Endowment as part of their Health for All initiative. This campaign highlights the important contributions of undocumented Californians to our state's communities and economy, while raising awareness of their lack of access to affordable health coverage. Here by telephone to briefly tell us more about the Health for All campaign is Marlon Cuellar, a program manager at the California Endowment Sacramento office.
Great. Thank you, everyone, for joining. A special thanks as well to all our colleagues at UC Berkeley, UC Berkeley Labor Center, as well as UCLA Health Policy Research Center for conducting the research for this report. This is such an important and timely discussion given current events. Like many of you, California Endowment has been concerned with our undocumented population and their lack of access to affordable health coverage. The Health for All campaign has been dedicated to driving a dialogue that will help move our healthcare system to one that is inclusive of everyone. Under the Health for All campaign, we have been following the President's executive actions on immigration reform and its implications for the health and well-being of Californians' undocumented population. Our goal with supporting this report is to provide useful information about deferred action recipients and their ability to gain healthcare coverage. This report also gives us new insight on how many people will continue to be locked out of affordable health coverage. Like you, we know that illness doesn't discriminate and that no one should suffer or die because of their immigration status. In California, the President's executive action brings us a step closer to securing a healthier future for everyone. However, the executive action does not go far enough. There will be others who are locked out of affordable health care coverage, and California needs to finish the job. We can all work together to make sure that those who are eligible for deferred action apply and enroll into Medi-Cal, and that we find a statewide solution for those who are left out. We encourage everyone to keep the conversation and momentum going at Health for All, and join our campaign by visiting the link that appears on the slide. With that, I'd like to now hand it back over to the presenters. Thank you very much.
Okay, well, happy to introduce this month's speaker, Dr. Nadereh Pourat, who is the Center's Director of Research and also, in her spare time, the Director of the Center's Health Economics and Evaluation Research Program. So she wears many hats within the Center. Nadi is the co-author of this new joint study with the University of California, Berkeley Center for Labor Research and Education that examines the up to half a million undocumented immigrants that might be potentially eligible for expanded Medi-Cal under President Obama's recent executive orders. This is, of course, a pressing issue for California's policymakers, planners, and advocates, as well as for those who stand to gain coverage. So Nadi's work and the work of her co-authors, Laurel Lucia and Ken Jacobs at UC Berkeley, have been eagerly awaited, especially up in Sacramento. So it's my pleasure to Nadi.
Thank you, everyone. Thank you for all of those who took the trouble to come here personally, and all those who are taking time out of their day to join us here by on the web. So I'm going to talk a little bit more broadly than the publication that we just released last week and was mentioned, and hence the title is slightly different here. So I'm going to sort of put in some more additional background, provide some additional information from other research that we've done, and sort of flesh out the discussion and the issues that are currently going on in California around this particular topic. So for this presentation, I wanted to acknowledge my co-author, Laura Lucia, who worked on this presentation with me. And I'm going to hopefully successfully page down. There we go. Okay. So I just wanted to put this slide out because I think we can lose sight of what a diverse population California has, who we are, and our sense of identity. We have about 27% of the population of California is born outside the United States, and of course many, many more who are second generation or third generation. So we have a huge number of proportion of the population that's immigrant. About 40% speak a language other than English at home, and another 47% speak another language in addition to English. So we have people that are quite diverse also in terms of the language capabilities. 53% of the immigrants in California are from Latin American countries, 36% from Asia, and of course, many from other parts of the world. Among all of those immigrants, over 2 million are undocumented. And I wanted to sort of spend a little bit of time about the different numbers that you probably have seen as you look at data that's presented out there. We have done estimates of undocumented population from the California Health Interview Survey in the past. It was about 2.2 million in 2009. Now, at a much earlier date, our numbers were consistent with other estimates, and over time, our numbers seem to diverge a little bit. And we have been spending some time looking at the reason for this divergence, and we know that it has a lot to do with the methodologies that other people have used to calculate undocumented. Most importantly, the fact that a lot of people that some people fall through the census numbers. So census does not capture everyone, and in terms of the undocumented population, it's probably a little bit larger proportion of the undocumented that do not get captured in census data. So that's part of the reason there are differences. I think one study has found about 10% of Mexican-born undocumented individuals are not captured in census. So that gives you a sense of how many people might fall out. Another reason is for the divergent estimates is because of the data that's being used, and as well as the methodology that's being used. So some people are using the immigration data, some people are using the Survey of Income and Program Participation data. Each one of these have different types of data in them, and then the they use, therefore, lead to different estimates. So I think it's just useful to know that little piece of information. And so the reason we're actually here and talking about this issue today is the fact that healthcare reform did not cover everyone. So healthcare reform left out the population that does not have documentation, provided some exemptions for other people as well, but the undocumented are one group that are systematically left out of healthcare reform. And when you look at the population of undocumented and their character and their insurance coverage particularly, you see a very different picture than what you would have seen if you were looking at the US-born population. In this particular slide, you can see that among children, undocumented population, only 16% are uninsured, but another 53% that says that have public insurance are actually those that are receiving emergency health. So restricted scope Medi-Cal, it is not full coverage. It provides emergency coverage. So in effect, you're looking at a primarily uninsured population. When you look at children, for the adults, the number that have nothing, no insurance coverage is actually quite large, 49%. Another 26% might have had emergency Medi-Cal coverage. So they would have had, some emergency that led to receiving that kind of coverage, but again, that is not comprehensive, does not protect people from any health problems or adverse health problems. So there has been in the past few years a call for immigration reform. I think everybody in this room probably knows about that quite well. And there has not been a reform the way that some of the advocates are calling for, but President did 2 consecutive executive actions over the past few years, try to address some of the issues. And those 2 executive actions were designed to provide deportation relief and provide work authorization. Primary goal of those 2 executive actions. There are some other consequences which we're going to talk about briefly. So in June 2012, the first program was called DACA, Deferred Action for Childhood Arrivals. And we'll talk about some of the requirements of that program. And then in 2014, the DACA population was expanded somewhat, as well as a new population was added, what we're calling DAPA, which is deferred action for parents of U.S. citizens and other legal permanent residents. So those are children primarily that have been born in the U.S. or have legal status. So a little bit about the eligibility criteria for these programs. The current DACA, this is the current DACA program, so it is expanding from the previous one. So you have to be in the U.S. without legal documentation, at least 15 years old at the time of application, to the U.S. before age 16. Now, previously, there was an upper age limit, which was under 31 as of a specific date. So that requirement has been lifted under the new expanded program. That's one change. And then continuously reside in the U.S. since January 1, 2010. The first program had a different date because it was just a few years ago. So that has also changed between the previous DACA and the current DACA programs. Currently attending school or graduated from high school or have a GED, that's the equivalency, a high school equivalency, and or a military veteran that had honorable discharge, and also have been convicted of certain have not been convicted of certain criminal offenses. So those are the criteria for being eligible for the DACA program. The DAPA program is a little bit simpler, and it is, again, individuals that they do not have lawful immigration status in the country, parents of citizen or legal permanent resident children, have continuously resided in the U.S. as of a certain date, were present in the U.S. As of a certain date, and have not been convicted of certain criminal offenses. So, yes? I believe you have to meet all the criteria. I don't, it's not narrowly defined. So something that is also unique to California probably, undocumented immigrants, including those with DACA or DAPA, are not eligible nationally. They're not eligible for coverage options under ACA, right? I've already mentioned that. But under state policy in California, immigrants with deferred action are eligible for full scope Medi-Cal coverage if they qualify based on their income. And that is what we set out to do. We set out to understand how many people are going to be eligible for Medi-Cal under this particular state policy, and also identify some of the characteristics of that population, try to help the debate about this issue. This is the policy brief that just was released last week. We're going to present some of the data on that one. And so just a little bit about them. I wanted to clarify that in the past we have done analysis of the DACA population and their characteristics. I'm going to show you a little bit of that research from last time in a little bit. But I wanted to say that we switched our analysis and used the current population survey this time around because we needed additional information about family status. We needed to know the exact situation for the entire family. So that's one reason we changed. We used 3 years of data this time in order to actually improve the accuracy or the reliability of the data. But we also are presenting all of that data for 2013. So that's the time frame where the data is applicable to. In terms of analytic methods, we had to identify parents or the situation, as I mentioned, for eligibility for DAPA. For the DACA, it's essentially based on the individual themselves. For both of these, that big list of criteria that I showed you, we don't have all of that information. So for example, we don't know whether people were in the U.S. and left for a few months and then came back. We cannot tell from the data that we have. We use years of residence in the U.S. as a proxy for the continuous residence. So there are some limitations to the data, and however, I think that we have, based on what we have seen with other estimates, our data have been proving to be relatively consistent and therefore we believe reliable. The other thing that we did is that we actually are not generating population estimates from our data for the reasons that I mentioned previously, the undercount and etc. So we are using the percentages, we are using the characteristics of the population from our analysis, but we're applying it to the existing population data that are available. So, and this is the data that we used. So we just did a canvas of the other estimates that were available. There are several groups that have put out information. Pew Hispanic Center has put out the number of the DACA and DAPA eligible. They're estimating about 1.2 million. In California, our colleagues Manuel Pastor and Enrico Marcelli have also done some calculations. Their estimates come about 1.6 million. And Migration Policy Institute has also calculated these numbers. Their estimates are highest. They come about, well, in this case, they're not highest, but in terms of overall undocumented population, their estimates are highest. So you can see that there are variations in the population size, and this leads to some of the uncertainty about exactly how many we are talking about. We use the Pew Hispanic Center data in part because we have used those numbers previously and we wanted to have some consistency in our estimates. So this is data from our analysis. What we have found is that about 68% of the population that is eligible for DACA is actually low income. And then 60% of that overall population is low income and does not have private health insurance coverage. For the DAPA population, we're looking at 65% and 56% respectively. If you put both populations together, you're looking at about 66% that is low income and 57% that is low income and does not have private health insurance coverage. So when I talked about restricted scope Medi-Cal, we are counting the restricted scope as uninsured for the purposes of these analyses.
Is this expanded DACA or is this all DACA?
It's all DACA. It includes everyone previously eligible and the newly extended program. Okay, so if you take all of these numbers, those percentages that I gave you, and then use the population size that we saw on the previous slide, this is the scenarios that we are going to be facing in terms of who's eligible and likely to participate, not only in the two programs, but also how many could be potentially eligible for Medi-Cal and also participate in Medi-Cal. So the orange arrow is saying that about 50 to 70% of California eligible for DACA or DAPA sign up, what would be, how many people that end up being? So that would be about 360,000 to 500,000 who would have no health insurance, could become eligible for comprehensive Medi-Cal. So this is combined DACA and DAPA. Yes?
What does it mean by full scope Medi-Cal?
Right. So the restricted scope or emergency Medi-Cal essentially covers mostly emergency room visits as well as pregnancy. So those are the two most common. There might be very, very small numbers of some other scenarios. Full scope Medi-Cal essentially covers all of the healthcare needs of all of the healthcare services that are available under the program, which is pretty comprehensive. So I'll use those two terms throughout.
I just had some online questions related to this. If you have deferred action, can you have full scope Medi-Cal? Do you mean DACA, not DAPA, or both?
Both. Both will have, could be eligible.
Okay. And then someone else wants to know the definition of low income.
Right. So the low income and Medi-Cal, we use the Medi-Cal eligibility criteria. So for children, the Medi-Cal eligibility criteria is under 267% of the federal poverty level. And for the adults, it's under 139% of the federal poverty level. Okay, so I just wanted to add one more piece of information to the slide, that 62% of Californians that are eligible for DACA under the original program so far have signed up. So you can see that, that the reason we say between 50 and 70% is based on available data. It takes time for people to learn about programs, enroll in them, etc. So hence the level of uncertainty here. So even if people are eligible, they would also have to take the next step and participate in the, apply for Medi-Cal, etc. And the estimate that we used was about 64%. This data comes from another study that we have done a little while ago, where we have looked at the likelihood of people that are going to participate in the program if they are eligible. And I'll talk about that a little bit more in a few minutes. So, why the uncertainty? Here's the answer. In terms of just to participate in the DACA and the DAPA programs, first of all, the DAPA and the new expanded DACA is on hold at the moment because of some court action. So that's not happening. The previous DACA, as far as I know, are still, you're able to work through that process, apply and obtain that kind of coverage. So that needs, that court action needs to be lifted before this program can go fully ahead. in order to participate in these programs, first you have to know about it. You have to hear about it. You're talking about, you know, so that level of understanding and knowledge has to be accomplished. As people have to hear about these programs and know that they can apply for them. The other important factor here is that you have to actually not be worried about any adverse outcomes to yourself and to your family members. If I apply for the program, what if there's a change in the government and things changed? If I apply for the program, can I endanger anybody else in my family that is not eligible for the program? Can I be at any other kind of risk in the future if I do this? So people have to just find the trust in them in order to go forward to do this. The other important factor here is the application fee and the, of course, application process. Currently, the previous DACA program was a 2-year program. So you apply, you pay about $465, and then you can get the status. 2 years later, you have to go back and do it again. The new expanded DACA and the DAPA, they try to change that to 3 years. So that will be better. It's a longer time period, but it's still only 3 years. Then you have to figure out how you're going to find the $465 every so often. If you have more than one person in your family that has to do that, you're talking about a population that has very low income, and that could be a serious barrier. Then you do the application process. You have to have the paperwork. You have to have everything in order before you can pass. I don't have enough information about people who fall through the application process and why they do. Maybe we can deal with that with the discussion. So once you get DACA and DAPA status, so that's the first step. Now you've done that. Now you have to understand that once you have the status, you could be eligible for Medi-Cal in California. So again, knowledge of eligibility is another factor that has to be addressed. You have to also not be worried about what if this will prevent me from anything else in the future. Is it going to impact my ability to get a green card at some point, et cetera, et cetera. And the application process for Medi-Cal, again, paperwork and all of those other factors. Just to add a little bit of context to this, for the DAPA population, we looked at the education status. About 31% had a high school diploma or the GED documentation. So you're talking about a population that may not have sufficient literacy or health literacy, etc. Among the DACA population, adults, about 96% do actually have high school diploma. And that's primarily because you're talking about people that have spent a lot more time in the US and came here much younger, so they probably school here. It's just a different profile and different capabilities there. Okay, so once you receive DACA and DAPA, remember we were talking about this being essentially the goal of the program was to provide protection from deportation as well as ability to work. So that ability to work could change the picture here a little bit. You could then, if you have work authorization through DACA and DAPA, you could get employment that you were not able to get before. You could get a different job perhaps. You could get a better job perhaps. You might be able to get a job that offers coverage. So your work status could change. Your work status could change your eligibility status for Medi-Cal. And then the number of people that will get Medi-Cal coverage could go up or down. So there are other, once you get work status, ability to work, other things can be affected. And again, this is explaining some of that uncertainty that I was talking about. Some of the existing data show that about 66% of the DACA and DAPA eligible adults working in 2013. So we have data from our study that about 63% of the DACA and DAPA eligible adults were working. So large number working, but the jobs that you might be able to do could be different after you get the status. National Survey of Youth had found that were granted DACA found that about 60% were able to get a new job, and 45% showed increased earnings. Those are important factors in this whole discussion. About 5 to 10% increase in wages was observed from those data. And 21% had obtained health insurance. It's not clear exactly what kind of insurance. Some of that could have been Medi-Cal in California. So I wanted to spend a little bit of time now into other characteristics. I talked about 2 characteristics. I wanted to provide a couple of more pieces of information. One is the age. Age obviously is associated with health status, and age has serious implications for utilization of health services. That's why this number is important. And that first bubble here that is supposed to be blue is not, so please note that that's just an error. So DACA eligible population, remember, they're all quite young. A lot of them are quite young. So we're talking about 30% of that population are children ages 0 to 18. About 61% are 19 to 29. Remember, previous DACA had eligibility cut off at about 30 years. So it was a lot of young people included in that first program. And so this new 9% that you see here, a lot of it has to do with expansion of the program. So now you're having some older people. And then eligible for DAPA, obviously, you know, we didn't have anybody under 18 in our data, but there will not be many people because you have to be, you know, you have to be old enough to have children. So there's not a lot of people out there anyway. And no, you have about 20% that are 19 to 29, but 67% are ages 30 to 44. So again, you're looking at a relatively young population, only about 11% that are 45 to 64. And our data, we didn't capture anybody over 65. So young population, most likely relatively healthy. And I'll show you a little bit more information from previous research that we have done that shows there are 2 reports, and also there was an article that's published by some of the colleagues. We did this work with other colleagues from UCSF as well. So this was a 3-university participation. And from that data, we identified lower rates of asthma, obesity, and binge drinking than US-born for the DACA population. This is the first program. We did focus groups with a lot of the DACA eligible population, and they reported high rates of depression and anxiety, trauma and stress related to undocumented status. A lot of anxiety and worry over the documentation status, and it's sort of a domino effect in a lot of different aspects of life. And then financial stressors, you know, not able to get a job, you know, financial stress on the family, on the individual, etc. You can see a lot of that information in the report, in those reports and the article. We also looked at access and service use for the DACA population. We found that more often lacked usual source of care. They had no doctor visits in the past years, more often did not have doctor visits in the past year, more often did not go to the emergency room in the past year. So you can see an overall underutilization of health care for the population. And from the focus group data, there was all of this information about individuals avoiding care as long as they possibly could. Anybody in public health will tell you, or you would understand already, that is not a good thing. Staying away as long as you possibly can until your situation is really bad is not a good thing. It sort of has negative consequences for everyone.
Your focus groups were all uninsured individuals?
I don't recall. I believe it was a mix. I think we really restricted Let's say that. And I think that there might have been some insured and some without.
It's interesting to know the
We'll have to-
differentiation in access and utilization between the uninsured and the insured undocumented.
Yes.
Can you repeat these questions when they're asked to you?
Yes, sorry. They were asking whether the focus groups included some insured population. The real answer is I don't recall, and hopefully we have, I think, some of our colleagues online that might be able to answer that question. We can repeat that afterwards. And the barriers to accessing care, you know, perhaps not a surprise to anyone. You know, cost, obviously, when you don't have coverage, cost is one of the major problems everybody faces. Not understanding enough about health, availability of health care services, resources, understanding what's important, what's not. You don't go, you know, one of the things that happens when you go for visits to doctors is you actually get educated about healthcare and how you care for yourself. You actually, if you don't go, you have fewer opportunities to understand more about your healthcare. Difficulty navigating the healthcare system. Fear and mistrust is a common theme that I think makes a lot of sense, and limited awareness of what's available, which I already talked about. I wanted to also provide a little bit of data from some other research that we did. This was published last year. We actually took a look broadly at the entire undocumented population, and also at the undocumented population that doesn't have insurance coverage, to get a better understanding of healthcare utilization. And what we found is that overall, sorry, this is, I don't know why this happened. I can give you that number. Rick, you see that too?
There's no value.
Yes, that was not the same when I sent it to you. Okay. All right, so what you should be seeing here is 2.6. So in other words, what if you compare the undocumented population in general to the rest of the population, divided into the categories of different types of immigration status or citizenship status, you see that the undocumented report about 2.6 doctor visits in a year, and as compared to the U.S.-born population, it's a significantly lower number, which is about 2.9. So lower rate of doctor visits for the undocumented population overall. And we have the same problem again. So then what we did is that we wanted to know, are there variations within the undocumented population by insurance coverage or type of insurance coverage? And as you can see, the uninsured here are reporting 1.6 doctor visits per year. And as compared to the undocumented that actually reported having coverage, if they were in HMO, they report about 2.5. If they were in PPO or the, fee-for-service, if sort of an equivalent, is about 2.7. Just to put this in context, an average person, I mean, you think about it. I mean, kids that need to have regular visits for baby visits, all of that, the number of visits should be more. If you think about adults, any of us, we probably go to the doctor at least once a year, hopefully for a preventive visit, and probably another time we go for, maybe bad flu or some other reason. If we have chronic conditions, we should be going to the doctor about once every quarter, roughly, right, depending on the type of condition. So you can sort of put these numbers in better context a little bit when you see such a low rate for the undocumented population. So don't go to the doctor means you don't get preventive care. Don't go to the doctor means you don't get maintenance care if you have a chronic condition. Then we also looked at, I'm just reporting the numbers within the undocumented population here, but I will also verbally tell you the overall rates. So we found also differences in emergency room visits, right? The number here is 9% reported, of the uninsured undocumented, reported having gone to the emergency room. If they were covered, under HMOs, they reported 14%. The US-born reported number was 14%. Okay, so that's been one of the persistent myths out there, that the undocumented are the ones that are crowding the emergency rooms. And I think it's really important to point this out. This is not true. Undocumented are not crowding, uninsured are not crowding the emergency rooms necessarily either. Yes.
Would you say what you mean by adjusted rates?
Yes, so the data that I'm reporting here is controlling for all of the individual characteristics. So instead of reporting the raw numbers, I'm sort of controlling for age, some of those other factors that determine why somebody goes to the doctor, some of the chronic conditions, etc. So it's sort of controlling for those. Thank you for reading it out. Yes?
Just to clarify, is it 14% of undocumented immigrants with HMO?
Yes.
Or,
Yes, so 14%, the question is this 14% of undocumented with HMO coverage? Yes. And a couple of other important statistics, when you look at the rate of preventive care use, so we had access to this information and we used those.
That's not my question. She missed it. What does the value mean?
It's unfortunately did not translate between one version of the document and another. That value was supposed to be 9%. All right. In this case, missing number is supposed to be 70%. So so you're looking at the different rates of mammogram by insurance coverage. Once again, if you're undocumented and uninsured, the rates are lower. And if you looked at the US-born population, that number would be about 79%. Now, I know that this number is still quite high, but what you have to remember is that sometimes there's a lot of outreach in different areas, and there might be venues where people that don't have insurance coverage will get these kinds of services. Michael?
Could you please define what subset of undocumented adults is referred to? I mean, clearly it's women. Women of what age?
Yes. So this say, I have to remember whether the age cutoff, I believe, was 50. So it's women over 50 years of age for mammograms. Obviously, it's not going to include all men because it doesn't apply.
Would ever gotten mammograms? Is it ever or past 3 years?
It's current.
It's current.
So it'd be 2 or 3 years.
Yeah, I think it was the last 3 years, but I've double checked. It's not ever. I think the survey question asks about mammogram. They have people from CHIS here. We can clarify that later. Thanks. Okay, and then another one, looking at the colorectal cancer screening, the number there should be 33%. The missing number here is 33%. So much lower rate of colorectal. Now, colorectal is ever, and it could also include FOBT, which is just a test that gets done in the primary care office where they do a stool sample. So it's not all, it's a combination of all the different colorectal cancer screening services. And you can see a lot lower rate. And this one, for the US-born rate, you're looking at 55%, which is the same. So essentially, all of this data tell you that if you do have coverage, the behavior of the undocumented with coverage is at best about the same. The rate of utilization is about the same as the average US-born. It's never high. But the other thing that it's telling you is that people are not using services in general. They're just using less of everything. And as I said before, we want people to go for primary care services. We want prevention. We want to address chronic conditions early. All right, so what's happening moving forward? Particularly in California, we have a pending legislation in California to provide coverage for all, okay? And the language of the bill has not been released yet, so we don't know exactly the details. So there was another version of this bill that was that was introduced a year ago. And essentially, the idea is that we are going to try to cover those that are income eligible, hopefully, for Medi-Cal under the same mechanism. And for people that are above that income level, we're going to try to provide coverage, other coverage options. And if you look around, you'll see some of the language from the previous bill, and we don't know exactly what the new bill is going to include. But this is an important point of discussion here, why we are talking about all of this. There's as I think our TCE colleagues pointed out, there's a lot of effort to sort of close that big gap that was left after the ACA implementation. And one other interesting research that was released about a year ago, last year, where we looked at what is the likely cost of it. And the research actually looked at what are we already paying. We are covering people for restricted scope Medicare at the moment, right? And if you look at the overall cost of that, what has been spent under that program, and you compare it with what's spent for full scope Medi-Cal, you can see that about 60% of those costs are already being spent. So a lot of money is already being spent for people for emergency services. So this is also helpful to understand, okay, if we do provide coverage, where is the money going to come from? I'm not going to get into a lot of detail. I think that this is a sort of a additional research that was conducted last year, and a somewhat complicated concept. Requires, it's available. I put the name of the document below, and I encourage you to have a look at that. And with that, I'm going to end the presentation part and open it up to questions.
Okay, and we're gonna do it this way. We're gonna take a question from the wonderful people in the room, and then we're gonna take an online question just so they don't get mad. Okay. So let's start with someone in the room. Any questions for Nadi?
Within your research, do we look at the average income for DACA and DAPA?
Yes, so we did. The question is, do we look at the average income? You want to know exactly what the amount of income was? No, we look at poverty level. So we know what is the poverty level, but we have not actually looked at that income level for the individual. It gets a little complicated because you have to look at the income for the family, and and so even if you know the income for the individual, you don't know how many people are actually using that money for for things.
The reason why I ask this because, for instance, for an individual that may qualify for DACA, if they're earning minimum wage, then they no longer qualify for Medi-Cal. So then that disqualifies them from getting Medi-Cal, and it also disqualifies them from getting covered California coverage. Right. So it would be interesting to kind of find out what are the median incomes between the DACA and the DAPA, and why are they not qualifying? Is it because also under their income they're not qualifying for Medi-Cal?
Right.
Could you just
recap? Well, I think essentially you're talking about the fact that it's important to know what's the actual income, because given the amount of income could impact on Medi-Cal eligibility.
Exactly.
So really summing it up briefly.
Okay, Nadi, there's a quick question, which is the $142 and the $94 the monthly cost?
I believe so.
So could you repeat?
Oh, the $142 and the $94 are the monthly costs.
With full cost Medi-Cal coverage for all, the cost would be less than the current restricted Medi-Cal. Is this the case? If so, how do we share with policymakers?
I'm not sure how to answer that question. So I don't know about the cost as much. I suggest that people read that publication that I listed there, and also contact the lead authors of that. I believe Laura Lucia, who's my colleague at UC Berkeley, would be able to answer those kinds of questions. I know there's a lot of speculation. Remember, this study was also a little bit later, so we have not repeated that study to also know what's happening with these new requirements and the new numbers of eligible. Things could be different. So this is a little bit older data.
Anyone in the room?
Ying?
Have you looked at agenda variation for these eligible?
We didn't this time around. Previous one, oh, the gender variation. Sorry, I keep forgetting. So we did look at gender variations in the previous one. I don't recall what the numbers were, but it is in the previous reports. This time around, we did not break it up.
Okay. We have a question from QED. Is the $142 being spent only on those who would partake of the benefit, or is that the estimate for all undocumented immigrants, whether they are in emergency Medi-Cal or no?
So I think this number particularly was the $142. The question is about the $142 and who does it include? Where does this number come from? I think that it's all of the dollar amounts that were spent under restricted scope. So by definition, it should include everybody that had used those services, and then that number was used and compared to the dollar amount that was being, if those people were covered, what would be the cost? So that was a comparison between the two.
Could you please comment on the implications of your work for other states? You know, so what's been the what variations there? So is this representative?
Yeah, that's a really good question. The question is if this is representative, our findings apply essentially to other states. I guess some of it would apply and some of it might not apply. Remember how the undocumented population is dispersed nationally. There used to be a time where California, Texas, a handful of other states were essentially where most of the undocumented resided. That's no longer really the case. I think the undocumented population is now quite spread out in the country. How the characteristics differ by state, given the fact that undocumented populations are here because of work opportunities, people are looking, like many other immigrants, people come to the United States for better life opportunities, particularly work opportunities. So I suspect that the characteristics of that population is going to differ, but why they went to the other states. I think for example, when Hurricane Katrina, led to a number of people going to that state because it was all that construction possibilities. So I suspect there will be some differences. There will also be some differences in how a state, do they actually cover, what is their cutoff for Medicaid coverage in other states. So some lessons that are applicable, there will be some underlying differences between states.
Okay, not if you can answer this question, but the question is, do we know whether SB4 will address any of the other identified barriers to participation?
No, we do not have the language of the bill, so I don't think we can comment. The question was whether SB4, SB4 language will address some of these barriers, and we don't know. We don't have the language of the bill. Yes.
Okay. Did the focus groups or your study of the surveys look at those identifying having a medical home among the responses?
Yeah, I don't recall the information. I think there was a discussion. So the question is whether the survey and the focus groups looked at having a medical home. Now, the term medical home is a little bit different from its common use. So if you So if you think about the usual source of care is something that we did look at from the survey data. And as I showed earlier, the population had much lower rate of usual source of care, significantly lower. In terms of, and I think there might be some additional information in the focus groups if you read the report about some of the barriers about identifying a provider. I think one of the interesting things that came through in that focus group research was the kind of places that individuals actually try to use to get medical advice and help, anywhere from pharmacists to traditional healers to parents, anybody who knew how to help you. And if the situation is serious, this could be a real problem, again leading to later and more severe issues.
We're having a very lively online debate, but I can't tell if these are actually questions.
Yeah, something on SB4 being available after next week. So it's going to be the language, everybody expects the language of the bill to be available very soon. Michael, you know something?
Sure. Yeah, this is very interesting.
Remember, I have to repeat you.
Can you please comment on the limitations of full-scope Medi-Cal so that the audience understands how it compares with, say, HMO, routine HMO, as a source of access to care?
Okay. So the question is, can I comment on Medi-Cal and some potential issues that could be associated with having Medi-Cal coverage as opposed to private insurance? So there's one major change that has been happening in the state recently, and that is that the great majority of the population is being moved from fee-for-service Medi-Cal to managed care. Now, some people may not like that, to be part of the managed care organization, but the reality is that it actually could improve your access quite a bit, because not everybody is willing to see patients with Medi-Cal, particularly under a fee-for-service system. But if you're part of the managed care organization who is dedicated to seeing individuals with Medi-Cal managed care, at least in theory, you will have a usual source of care that you could go to and you can get the basic services. So that, I think, is a positive change with whatever limitations, narrow networks, whatever, lots of different issues that have come up. Other than that, Medi-Cal benefits are quite comprehensive. But there could be issues still within HMO. There might be other unforeseen barriers. I mean, you can highlight some if you like.
Well, I think the main one is economic. Because of the low reimbursement rates, you have very few, a very smaller group of physicians that are willing to accept it. That portion of physicians that are willing to accept Medi-Cal decreases significantly when you're talking about specialists.
Right.
And so that has a major impact with regards to access to specialty care. So even though theoretically they have the access, in practice it's very limited.
Right. So what was just discussed is that access to services may still be limited under Medi-Cal, particularly access to specialists. And that's primarily because of it has a lot to do with the reimbursement rates. So I think that some of the issue of the reimbursement is going to be different when you're under Medi-Cal managed care because of capitation, because you're no longer paid per service, which, I mean, you could get for a visit. I don't recall exactly what the amount is if you were under Medi-Cal fee-for-service. For example, you could get like $18 for a visit from Medi-Cal as opposed to, I don't know, maybe $50 from private insurance. I'm not using real numbers. I don't know exactly what those dollar amounts are. So that has been a problem, and that's why I said that being part of Medi-Cal managed care could have an advantage. Now, what happens with Medi-Cal managed care is that you actually now have a network of providers. They're committed to providing care to the population, but it's a narrower network. It's not everybody who's participating in those networks. And even if you're in a network, a provider might close to new patients. So they may only be they may only choose to see patients that they have been seeing before. So there could be some barriers. It's right now I can't share any real numbers in terms of what's happening, but those are some of the issues that have been present. Having Medi-Cal coverage doesn't answer all of the problems. One of the issues that I think is very important, just giving somebody Medi-Cal coverage without linking them in to providers who will actually go that extra step, become a medical home in its ideal sense, proactive medicine, call the patients who need to come in for their next diabetes check visit, bring patients in when needed. If we just provide coverage, but we don't take that extra step of making sure that people are actually, their care is really managed, we are still looking at high costs and some of the other issues that have been plaguing the U.S. healthcare system. Gwen?
Sorry. Yes, I think that's it. We're going to let her take a breather. Thank you very much, Nani.
Thank you. Thank you.
Full house. That's amazing. I know. Hot topic.
Hey, thank you for your, yes. I'm around this. Stand right. The camera, I think they cut it off.
So it reminded me of the meeting to sit down and figure out how we're gonna present it. I mean, we have a report, but we don't have any slides or anything, right? And that's like in 2 weeks.
Right, I know, it's nice.
Yeah.
Yeah.
No, if
This
you would like
report
a
didn't go
presentation,
there.
please go out to the desk, the receptionist right out there, so we can call it.
Oh. I'm good.
But we have to do 2, because we have to do a 40-minute one for here and then cut it down to
Yeah, I wanted to introduce